I've had the opportunity to review surgery on the mobile surgical bus, which travels around the country in 5-week cycles. They are very complimentary about the Honourable Annette King, who helped them instigate that service when she was the Minister. It's a great initiative, and it takes the pressure off waiting lists and patient travel for minor surgery. Recruitment and retention of GPs, along with access issues for patients because of locality, especially after hours, along with limited resources and training for rural healthcare workers, are all common examples of the challenges we face. Clinical engagement makes a difference, not just to the morale of the District Health Board, but also to community rural health providers. A community is mostly the best way to work out how its needs might be solved. We rely very heavily on many volunteers in our regions. They are the glue of our regional communities. It's great to see rural organisations working collaboratively and taking a multifaceted approach to improving the lives of New Zealanders in rural communities. I just want to talk a little bit about mental health, because it's something we don't always focus on when we're talking about health and medicine, but I see that as a priority. It's important to raise awareness and to encourage people to seek help. There is a lot of work being done by a range of groups, including the Mental Health Foundation, Federated Farmers and the Ministry of Health. Yes, the low payout for dairy farming at present does affect the economy, but please remember it affects the farming businesses and their surrounding support businesses, and a lot of small communities are affected by this. It will come right, but we have to take care of our people when there is a downturn. And I just did a 60-kilometre bike ride. We had a group of 27 people who had been affected by either mental health or family members with suicide who did the whole South Island. And a few of us actually did the last 60 kilometres with them. And they actually raised $150,000 at the Taranaki Rural Support Trust, plus a whole lot of awareness about mental health, because generally rural people are quite stoic and not comfortable to come forward. So that's a huge issue at the moment. The other issue I wanted to focus on is obesity, because New Zealand is not unique in its battle with obesity. There is no single solution, and there are a range of possible interventions. Where is the line between self-responsibility and intervention? That's a hard decision for politicians, as there are a range of views on the political spectrum. And there's another bike ride going on next year around farmers aren't as fit as they think they are, and that's going to go from Coromandel all the way down to the bottom of the South Island, because actually farmers used to run around a lot, but now they're also on farm bikes and they have big equipment to do those jobs. So it is a rural issue as well as an urban issue. And last week I had a director of Southern Cross Healthcare tell me that no longer are the majority of claims for heart and cancer, they're shifting to hips and knees, which is an effect of obesity. Then on to e-health initiatives. They offer solutions, offer better, safer, far more efficient primary health care. Increasing the use of telehealth is also a key enabler. It can make a huge difference to people living in geographically isolated areas. But this relies heavily on rural broadband and connectivity, so I'm working as hard as I can with our Minister of Communication to understand how we can get that connectivity delivered even faster. And then there's workforce. On Thursday evening I opened the Rural Mobile Health Conference in Wellington. The average age of their nurses is 55. They will retire, although I believe the eldest is 85, so it will be a while. We need more of the best and brightest being recruited into our regions. Please come. There's good evidence the best solution to rural health workforce shortages involves selecting students early from regional and remote centres and maintaining their exposure to the challenges of rural primary health care throughout their education. I'm aware of a number of workforce initiatives, including the voluntary bonding scheme, which incentivises graduates to work in hard-to-staff communities. To date, over 800 health professionals have been funded through the scheme. Is that 6 minutes? Medical immersion programs where medical students spend an entire senior year in a rural area, and I've been informed that there's evidence that medical graduates of the University of Auckland's long-term rural immersion program are returning to rural areas after graduation. A new challenge is to find ways of encouraging a grow your own in relation to people, a strategy outside the main centres to encourage career changes or mature students into health. I know the challenges of traffic jams out of Auckland on long weekends and holidays. You all love regional New Zealand. Please come and join us. Thank you.
Kia ora tātou. Thank you very much for the invitation to be here today. Professor Fraser, my parliamentary colleagues, I particularly want to acknowledge Kevin Haig and hope that he becomes the co-leader of the Green Party, Tracy and Barbara, and to say that Kevin and Barbara and I make up the Health Select Committee, or part of the Health Select Committee, and it's a committee that has worked incredibly well over the years, a cross-party approach to health. In fact, in 2013, we produced a report on children's health, and all the recommendations in that report, New Zealand First was part of that too, Tracy, the recommendations all came from the best information and evidence that could be provided to us. And those recommendations, I think, were incredibly good for children's health. And I mention this because it does lead on to the topic of this debate today, which is set sail, the course for a healthy future. Are we on the right track? And to decide that, I think we need to answer 4 key questions. The first is, do we have good data and evidence on which to base policy decisions leading to a healthy future? Secondly, does the government base decisions on evidence and good data, as recommended by people such as the Chief Science Advisor to the Prime Minister, Sir Peter Gluckman, our leading scientists and academics? Thirdly, do we have a long-term strategic approach to achieving a healthy future? And fourthly, are we evaluating what really determines progress towards a healthy future? So from my perspective, going through those 4 questions, there is no shortage of good evidence and data, both New Zealand and international data. We've got data on the prevalence of NCDs, on the health system usage, on mortality, socio-economic deprivation, burden of disease, cost pressures. We have the Health and Quality Safety Commission collecting data. We have the Atlas of Health Variation, the Ministry of Health's annual survey, which tells us 3 out of 10 adults are obese, 1 in 10 children, that 18% of adults are diagnosed with a mood disorder, that children and adults living in deprived areas are more likely to miss out on their prescriptions. We have evidence from Diabetes New Zealand. We have evidence from Asthma New Zealand. We don't have some data. We don't have data on the unmet need for elective surgery. We don't measure child poverty. We need better statistics for Maori and Pacifica Health. So we have very patchy data on health workforce. So we do have data that we can make many decisions on. Secondly, the government's decision on health priority, I believe, is not often based on such evidence. Let me give you some examples. Take rheumatic fever. It's a priority to identify and treat, but not to tackle the cause of rheumatic fever. And as you will know, it's poor, overcrowded housing and poverty. We know that we have a growing number of people with NCDs in New Zealand. Big burden of disease coming up in the future. Diabetes, 240,000 people diagnosed with diabetes, and another 100,000 don't know they've got it. Respiratory disease. Bronchiolitis has increased by nearly a third between 2000 and 2013. Cardiovascular disease, arthritis, cancers. And we all know that a major cause of these diseases is actually obesity. So what has happened in terms of obesity? Barbara talked about some of the things that are happening now, but for 7 years we've done nothing. In fact, we cancelled the Healthy Eating, Healthy Action program because it was called nanny state. And only now are we starting to see some priority go back onto addressing obesity in New Zealand. We cut public health funding. The very programs that are there to help tackle some of those issues. And in children's health, we know the difference between and providing health services in those first 3 years of a child's life. In smoking, we have made some progress, but we're not going to pass the plain packaging legislation until after the court case for Australia at the WTA is heard, and that could be many, many years away. We have an ageing population, 675,000 over 65 now, and we're going to have 1 million by 2025. So where is our preparation for care in the community? Where is the training of the workforce we're going to need for that? The third key question is, are we taking a long-term strategic approach to the healthcare future? My answer to that is no. We take a short-term political tick box approach and a league table approach where we publish whether they've got to the ED department in 6 hours or not. Whether in fact we have got, we're waiting too long for surgery. In 2011, Minister Joyce, in what I think is one of the short-term tick box targets, was to limit the student loan for 7 years. It affects everybody in this room if you have undertaken a previous degree. You know, the New Zealand healthcare strategy, the primary healthcare strategy, the palliative care strategy, the older person strategy, all those were produced under the last Labor government. They all need updating. But I have to say, the former minister, and I hope the new minister doesn't have this belief, he said he didn't believe in a strategic approach to health, he just wanted action. If you've got to have a long-term approach, and I firmly believe in it, if you know what you're doing and what you're going to measure. And the fourth thing is, do we evaluate what we need to? Well, the answer to that, I think, is sometimes. But often, it's not done by government agency, or it's not available. It has ceased altogether, for example, like the child health monitor. So child poverty is not allowed to be officially measured in New Zealand. It is too political. And as for the health workforce, we take a short-term approach. And I think for medical students, there is an absolute lack of career planning advice coming from Health Workforce New Zealand as to what you should be concentrating on and our needs in the future. So I think it's time. I've given the government 5 out of 10. I think it's time for some, and that's just the time. It was 4 and I upgraded it to 5, to be fair on the new minister. But it is time for some forward thinking based on the evidence and data that is provided. We need to set priorities in New Zealand around what we know needs to happen. We need long-term planning, we need honest and open measurement, and we need a health budget that meets the cost pressures and the unmet need in a first world health system. And I'm going to finish with Professor Fraser. We need a health service fit for purpose. Kia ora tātou.
She's an awesome politician, and one who I particularly look up to and watch in the House the ways that I can improve. Secondly, what she doesn't know about the health system of New Zealand is probably not worth knowing. So, but I am going to follow the Honourable, I'm going to say Honourable, the Honourable Annie King, the right Honourable she should be. So with regard to New Zealand First and whether we're on the right track, so this is our take on it. And I don't sit on the education, I don't sit on the health select committee, I sit on the education and science. So a lot of that, what I'm going to talk about too, is around the cuts that have come that are affecting downstream the education system, the workforce planning that's non-existent in our view, and other areas that we need to focus on. And if we're going to say, are we on the right track? The question is, are we on the right track? There are actually a couple of places in New Zealand that are on the right track, and I'd point to the Canterbury DHB and the work that they've been doing since 2007 around integrated care and social services. There's some great work going on at Counties Manukau and in the Bay of Plenty. And the Counties Manukau is more family-focused and so on and so forth, where the Canterbury DHB, a lot of its work has been focused around that older generation and the numbers that were being predicted. And it's what Barbara talked about and what Annie talked about. It's the change that we need to make and that we need to fund to actually shift that focus from sending people to hospital to keeping people at home. What that requires is a lot more conversation between general practitioners. How many people in this audience intend to be GPs? How many of you intend to be GPs in Tahana and or Portuguese and Te Ao Mutu? Thank you. Who intends to be GPs in Epsom and Remuera, and fair enough. But the point I'm trying to make here is that with regard to that particular demographic, the age demographic, they're moving out of the main centres. They are the ones that are selling their homes, moving out of the main centres and moving into the rural communities, into those smaller communities. And they don't have to move very far. I live in Warkworth. We have no 24-hour care in Warkworth. It's a 25-minute drive after hours to get to a sort of a main emergency centre in Red Beach, and if they're closed after 10 a.m, then you've got to go on to North Shore. And we're in the super city of Auckland. And there is one doctor that holds the fort up in Wellstead for the whole of that community around Tahana and so on. He goes to every car accident, Tim Malloy, he goes to every car accident, he goes to every attendance that he can do. So there's an emergency out in rural New Zealand with regard to our current health system. And what Canterbury's doing and what it has shown to do, and the evidence since 2007 and the escalation in its work since 2011, is that the conversation between specialists and GPs needed to become much more collaborative. And that's what they've been doing. They bring in also the district health nurses, other public services, the community volunteer organisations, and as a team they create that front end of the environment when the human, the client, shows up at the GP's office and the GP can assess, working with the specialist, they can assess what are the tests that need to take place now inside the community. How is this person's depression actually adding to their need for medical services? How can we hook them into something else? And the Swedish model is really, really interesting. Same sort of work going on in Sweden and some other nations, but the Swedish model has set up things they call living cafes. And so they take place in many different areas outside of the community. Some in gyms if they're talking about physical movement, others in coffee shops where they talk about how they bring the client together so they can talk about how they can improve their own health inside that community. And the wonderful work that's being done with these pilots has saved, in Canterbury, it's saved them from having to build another 200-bed hospital. But what we're really, really good at in this country is that short-term thinking, which is, well, we saved ourselves 200 beds, so we won't have to spend that money. That's great. We'll let these people keep doing this pilot, and as soon as it starts working, we'll withdraw even more money out of that budget because we can see that we don't have the numbers going into the hospital, so we'll take that money away from that budget. But what the GPs are going to need, you as GPs are going to need more resourcing than you've ever needed before. And our communities are going to need more resourcing than they've ever had before at the front end of that spend. So the other thing, and at the moment, one of the challenges to being a GP, or my understanding is that you're pretty much on the financial return, you're around about the bottom rung. And if you go into an area like Tahana or Te Awamutu, where you have a large client base that cannot pick up the difference between the government subsidy and what it actually costs you to provide that service, then you've become a volunteer organisation almost. So from a New Zealand First perspective, we see that there are some tracks that we are on that are working really well for our community. They need to be expanded, they need to be resourced, and they certainly deal with many of the issues that Annette talked about with regard to that, particularly the ageing of our community. But they're not funded appropriately, they're not front-ended, and when, say, New Zealand First comes up with a concept which is, say, three GP visits for gold card holders, that's laughed off as an election bribe. Whereas actually, it's an extension of what's currently happening in Canterbury. Before the older person gets sick, go and see the doctor for a checkup, and let's pick it up before it becomes something that they then need to go and see the doctor for and get a barrage of tests. What would happen if we actually thought about front-ending all our spend? So, from a New Zealand First perspective, there are things that are on the right track and there are things that aren't. The last thing we need to talk about, though, because I'm sure I have less than a minute, is your debt. Is your debt. The number of you that will go overseas, because when you leave your education, if you can afford to finish it, the number of you that will leave here and go overseas, you are New Zealanders who understand New Zealand. You understand the communities that you want to work in. And those are varied. The New Zealand Indian community needs more doctors that understand, particularly for the older members of that community, their way of life. They're New Zealanders. They deserve to be treated by people who understand how they live and how they need to be responded to. The same with the New Zealand Chinese community. And if you all leave because we've driven you into debt, then all we're going to do is bring a whole lot of other doctors into here who don't understand how this country works and how these people move within this country. So that's another area. We're not on the right track there in any way, shape or form. You should be not having to pay at all for your education, but you should have to pay your education back to your country by giving to your communities. Kia ora.
Greetings, Professor Fraser, acknowledge my parliamentary colleagues, great to see Brian Bruce in the audience today as well. Fantastic contribution he has made. You probably know that we have a rheumatic heart disease incidence that's around 17 times the OECD average. It's pretty bad, right? And those of you who've worked in peds will know that roughly half of the kids that get admitted to your ward will be admitted for skin infections or respiratory conditions. And some students from Wellington, the Otago School of Medicine based in Wellington, actually did a little research project where they tracked back those kids and found a very strong correlation between those skin infections and respiratory conditions and living in damp, drafty, cold, overcrowded housing. So, there seems to be something going on there. And I do a little thought experiment sometimes for an audience where I say, imagine a map of this country. We can do it with a map of the world as well. And then think of almost any condition that you like. I mean, choose, we've said rheumatic heart disease. So let's think of rheumatic heart disease now. Shade in the map according to which communities have high rates of that disease and which don't. And you can imagine what that looks like. Okay, now think of another disease. Let's take diabetes and do the same thing. Shade in the map for those communities that have high rates of diabetes and those that don't. And then take cardiovascular disease, cancer. Actually, almost anything that you could imagine, you're going to find those high rates are in the same communities. So that's a bit of a problem for someone who's trying to explain health and disease in terms of individual choices. Because the assumption would be then that people who are bad at making choices somehow cluster in particular areas. So instead, actually, of course, what it's about is that our health or our disease status is very largely a function of our living circumstances, our degree of empowerment, and the environments that surround us. And those inequalities in living circumstances are in fact getting worse. So while for me, I mean, my life expectancy is pretty good, it's probably going to be increasing, my health is good, I'm going to live probably into old age actually pretty healthily. That is not the case for a growing number of New Zealanders. Diabetes, for example. We now have one New Zealander in 4 over the age of 15 who either has type 2 diabetes or has pre-diabetes. 1 in 4. We are projecting that by 2021 we are going to be spending $2 billion a year on health services for people with type 2 diabetes. Currently, health budget's a bit over $40 million. So even for me, and I probably won't get type 2 diabetes, actually those problems of inequality are going to hit home. They're going to affect my life, they're going to impact on my access to health services. So these are, for any government, a really major problem that the government ought to be addressing, and it is not. I would argue that rising inequality is in fact is a result of the economic model that we use. We have set up, and human beings are the ones who have set up an economic model that's based on extracting value out of people. So people just become the labour input into the economy and serve the economy. And we've had a government for some time now that has essentially seen its job as to facilitate that process. That is what is driving inequality. And actually, it's also what's driving environmental degradation. Because if people are just the labour input into the economy, the environment is just the raw materials or the waste disposal input into the economy as well. And actually, we have to flip that round entirely. So when I say we're on the wrong direction, and I do, we're 180 degrees wrong. Because actually, the economy should be the toolbox that we use to achieve our environmental and our social goals, not the other way around. We have, in the past week, started to see the budget spin. So the most recent thing was the announcement. We have a record number of health professionals working in health services. I would predict that probably on Tuesday, they may wait until budget day, Thursday, to say there's a record number of dollars being spent in the health sector. Actually, yes, that will be true, but actually not enough. And in real terms, you are facing a pattern of increasing need with less real terms resource to meet that need. Entirely the wrong direction. And government might say, actually, we just don't have the money. But government is choosing to spend $20 billion on roads of national significance. So it's not a question of there not being enough money. It's a question of what the government is choosing to prioritise. And I maintain that they've chosen the wrong things. This is kind of like an outbreak of what I would call short-termism. I used to be a sailor. Sea of B. I used to live in Auckland. All my weekends were spent sailing out on the Hauraki Gulf. Government is like sailing with no navigation. Completely wrong. So you all need to get active about this. And there's various ways you can do that. I recommend Ōrātaio and NSGA. And if you're not doing anything on Monday night here in Auckland, 7:30 at the Rendezvous Hotel, the government's doing its token consultation on climate change. Just a suggestion. Thank you.
For somewhat similar but also different opinions on what is seen as wrong with our health system and what we need to do for it right. So as adjudicator, get some chance to say my own word before I open the debate up for questions. From my perspective as a dean of a medical school, there's a lot of challenges we face. Obviously, my primary responsibility is providing world-class education for the likes of you, and also the nurses, the pharmacists, so that we do have a workforce which is fit for purpose in New Zealand. We may say that there are a lot of things wrong with New Zealand's health system and New Zealand's health in general. I would argue that actually New Zealanders are by and large internationally a healthy population. We are very lucky to have a public health system. If I make some comparisons between New Zealand and the nation that we most look up to, or science look up to, the US, which economically is the powerhouse, the global powerhouse, they currently spend around about 18% of their total GDP on health. We, as a nation, spend about 9.7% of our GDP, so that's about half what the US spends. As a result, the US mortality rates are still about 460. So if you're between 30 and 70 years old, there are 460 out of 100,000 people who are likely to die. That's the mortality rate. Compared with New Zealand, which has a mortality rate of 300. And most importantly and most dramatically, our infant mortality rate is significantly lower than the US. Our infant mortality rate is around 4.73 deaths per 100,000. as opposed to the US, which is 6. So some of the statistics we have indicate that what we are doing in our health system is actually serving us well. But I think we would freely admit that there are some things we need to focus on. So we've heard today around some important points around, Annette made a very, very good point about the fact that are we basing the development of our health system on good evidence? I think that's a very good question. I would agree with you entirely, but I would say that yes, there's some good evidence, but in other areas the evidence is very patchy. And to make decisions and not having a long-term strategy around health is probably one of the most important things we need to focus on. So with that, I'm going to open up the floor to questions. I have a number of questions I'd like to ask, but I'm going to allow you to ask some questions. So what we'll do is we'll give you an opportunity to ask a question, and then I'll open it up to the panel members, and you can choose to answer or not. So I think the first question is going to be about student debt. Question in the back.
Thoughts on the downgrade of Dunedin Hospital? Anyone?
So it's a real worry because Targo Medical School is one of, along with Auckland, reputation. Any downgrading of that hospital, and I have to say there has been a little downgrading here in Auckland as well, around the ICU area. I think it is a real worry for us. We have to invest into our two medical schools. We want them to be acknowledged internationally. We want you as graduates to be acknowledged as coming out of the very best education that is available. And Dunedin Hospital is the last large tertiary hospital to be rebuilt. The problem for Dunedin is that the government is requiring them to get rid of their deficit before they will fund a rebuild. Now the problem, I think, particularly in the southern part of New Zealand, is the population-based funding formula does not fit well with a large geographic area like you have in the south. Now the biggest DHB area is the southern DHB. So you've got a large rurality factor, you've got a lot of unmet need, you've got an ageing population, and the population-based funding formula, which hasn't been reviewed for years but is being done now, does not fit that area, and it desperately needs to be updated, it desperately needs to have more funding go into it, and they need to have their hospital rebuilt regardless of the deficit they face at the moment, looking at 32 million. So, in my view, the government needs to go in and build it. It's a public hospital. The public fund public hospitals, and it needs to be updated. Leaking theatres, I mean, it is a mess, as you obviously know, because you're nodding. So yes, it is an issue.
I thought what Annie says.
It's in your booklet that I used to be the chief executive of West Coast District Health Board, and so I'm very familiar with those problems of diseconomy of scale. And actually, the southern DHB has those problems of diseconomy of scale, but also the problem of being a tertiary provider, which also has a higher cost structure that is not well met by the funding formula. So, and it's right to focus on the revenue stream. Just building on what Annette said as well around how should we decide what to spend money on. And my own perspective that I took to government when I had the opportunity to do that for West Coast was we should work out what the needs were, what the services were that were needed to meet those needs, what the physical infrastructure was to meet the needs, and what does that cost? Rather than saying how much do you actually have to spend, that's the size hospital that we can build for you, because that's the debt that you can service with your particular funding package. That is a model of decision making that is unrelated related to human health need. It seems to me that isn't how we ought to be going about the decision.
What I was just going to say, it is good that it is reviewed because not only in health but in a range of things, and I actually referred to regional New Zealand quite a lot when I did my presentation, was around, actually how we service the needs of people and how we get closer to those people. Admitting that, Dunedin is a medical training base, and I think that's really, really important. I don't understand the numbers as a UMP as well as Annette does, but what I do totally agree with is that we need the bestest and brightest people, whether it be in health, whether it be in education, and all of our, primary industries. I'm hearing that every day, and so, we do need to make sure we've got the best trained people who can deliver the best services wherever the people of New Zealand might need that. And we are on a journey, and I'm, really happy that these people are on the health committee with me because I know we're going to be doing a lot more talking about those things. Thank you.
So from our perspective, it's, again, you're our New Zealand medical future, right? So from our perspective, it's something that needs to be funded. That bottleneck needs to be, it's a priority for, we believe, what the government should. We know that we're going to, if we look at our workforce planning, we know that we're going to need you. We're going to need you out there. But to do that, we need you, first of all, inside hospitals being able to get those places. So from our perspective, it shouldn't be about, is there any budget left or what is the DHB's doing? It should just be a criteria that the government will fund, we will push you through, make sure you get through and have those places so that we can use you in the future for the country.
I agree in that there is an obligation on a government that brings in X number of people to train to ensure that they can finish their training by having the completion of that training. And we now have, and I don't know what's going to happen in 2015-16, but I'm told there'll be 423 PGY1s, and every one of them should be funded into a position. But so should the 20 international students, because we bring them here, we go out and tell the world we want the money from international students, that's good for New Zealand, and then cut them out of finishing their training. That is not right. And so we need to also fund those positions. But I've got to add to this, we do not have the equivalent of PGY1 and 2 for nurses. And some nurses receive what's called the NET-P program, and it's not going to be fully subscribed until about 2017. In the meantime, we have 25% of our nurses in New Zealand come from overseas, and we have something like 200 nurses who can't get jobs who trained in New Zealand. And it gets back to that fundamental thing, and it's health workforce planning. And so what I think Health Workforce New Zealand needs to be doing is working with you from when you first start your medical training, looking at where the openings are for you in terms of what specialties we're going to need. We know that we've got an ageing workforce in our specialties. I'm told that it's over 50. So there's going to be some retirements coming up. It's the same for nursing. And so we need to be encouraging our students into the areas, especially where there will be jobs, and working from the very beginning so you've got an idea of where you're heading. And one of the complaints I'm told from your student body is this lack of engagement and consultation on what is available for you going into the future. So workforce planning is the key to it. Funding those positions. Don't bring students into the medical schools if you're not going to be able to enable them to finish their training. And that is absolutely fundamental. And I think if I recall, every party here, these three parties at the last election, sorry, we committed to it. I'm sure Mr. Joyce will be looking at it now and wondering whether he's done the right thing.
Yeah, and what Anne says is quite right. That I mean, some of you will have been to previous conferences and heard me say exactly those same things. This is a classic case, really, isn't it, of that short-term thinking that I was describing, and lack of a sense. It's almost like the government thinks its approach to hands-off, hands-off the market, hands-off planning. Actually, let the DHBs do the planning. Well, actually, that is an approach that actually has an awful lot of casualties, and some of them really spring. Because that's not a smart way of going about this at all. A massive investment has been made by you and by the state into your education. And so for that now to be wasted because of that failure to plan and government's ideological commitment to not intervening in the market, it's a disaster.
Just going on the question before, what's your commitment to keeping us here in terms of, making sure that we have good working conditions when we graduate as junior doctors? It's a hard job, everyone knows it. So what's your commitment to making our lives easier so we want to stay here and work and commit our lives to New Zealand?
So part of that is around your working conditions, and I think what we've seen is across the board in many workplaces actually an erosion of working conditions. So let's just put that back out there. That from a New Zealand First perspective, the constant erosion of many of New Zealanders' workplace conditions needs to be addressed going forward. With particularly in your particular area, the number of hours that are being asked to be worked once you get into the hospitals, the rostering that goes on, that in our view, there's an area there that we need to look at, and that comes back down to, again, funding appropriately to make sure that, I'm not sure really whether working 25 hours or 23 hours gives you the skill that you need, as opposed to actually working with less and making sure that you've got a high level of academic oversight by those that are working with you. On the other side, about keeping you in New Zealand, we want to keep you here, I said that at the start, and there is a voluntary bonding program at the moment. We would expand upon that, but we would also do a dollar-for-dollar student repayment for those of you that stay here and work here, particularly those of you that go out into the Tihanas and the Te Awamutus and the Oportakis and so on and so forth. Because we see that the biggest driver of you overseas currently is debt. Once you get there, you'll realise, obviously, and those of you that have travelled, that New Zealand is a great place to be, and that there's many countries that are much worse that you don't want to go live in. However, if we're going to drive you into debt and keep house prices at a level where you can never own your own home and you can never go into your own business, why would you stay? So those are the sort of things that we're committed to.
I would say that the opportunity to travel overseas and to work overseas wouldn't stop you doing that for some time, but we want you to come back. There is some real advantage if you're getting some international experience. I'm sure Professor Fraser probably had the same experience. And so there's nothing wrong with you going and working in other places, but we need to retain you back here in New Zealand. So you need to come back and work in New Zealand. If you don't want to go away, we need to hold on to you. And it gets down to things like staffing levels and the pressure that are put on, particularly in hospitals, on specialists within hospitals, and the staffing levels, which goes straight back to what is your overall funding that goes into health. About 80%, 80% of the cost of running your health system is in personnel. So if you've got insufficient money, and if you have a look at this budget coming up, as Kevin said, there'll be more money in this budget than there's ever been in health before, but that would be the case if you put $1 more in. It's a matter of how much you put in and whether you cover the cost pressures. If you don't cover the cost pressures, the cuts will be in what is paid to the personnel that work within health. So you've got to have an adequate health budget to ensure the remuneration for your staff is sufficient to retain them. The other thing I'd say is when you graduate, join ASMS. They do a great job for you.
One of the things I've been doing in the last 7 or 8 months since I've been an MP has been going around my electorate and asking people lots of questions because, I can't represent people unless I go out and listen to them. And so I don't want all of your answers today, but what I would encourage you to contact each of us at parliament.gov.nz and tell us what you think would keep you here, because as Emmett said, we wouldn't want to stop you from doing OE, but we certainly want you here. We want the bestest, we want the brightest people, and I just think if you tell us what you want, we can't always give everybody everything they ask for, but what we can do is sit down and strategise about what it is that might actually keep you in New Zealand, because it's not only your industry, it's a whole lot of other industries, and for the Te Awamutus and all of the other places that Tracy mentioned, along with right here in Auckland, we do need you. So I'll turn that question back and say, you tell us, and it's our job to actually lobby our people to see what we can do.
Yeah, I'm not sure I can add very much. You'll know from our policies, we're absolutely committed to providing jobs for every graduate, in fact. And from where I come from, where we have chronic and acute shortages of medical staff, there's always jobs in Greymouth. It's a fantastic place. I think we're right about that. The one thing I maybe will add is that it's not only an issue for government, it is actually also an issue for the profession, because I actually have encountered many SMOs who have the attitude that, well, we had to go through this grueling kind of approach to being junior docs ourselves, and so if it was good enough for me, it's good enough for you. And actually, I suspect that that's not a very helpful attitude for achieving change.
Can I just add one more thing? Sorry, and it's around women in the workforce. So a very good friend of ours is Dr. Erica Winner-Kelly, and I know that Erica, when she specialises in breast cancer, and I know that she ran into quite some really interesting glass ceilings when she went to have family. So it's another area that I look at all the women that are here in this audience, and we need to keep these women inside the workforce as well. So that's another space that there needs to be a lot more work done by government and by those out in the workforce to make sure that we create environments where these women can also stay inside and keep their skills here for the country.
You talked about lateral blocks and thinking about the reasons healthcare. In your opinion, what is the main reason for this, and what would you do about it?
I only got 3 minutes. I think that what we've moved to, particularly in the last 6 years, has been to what I call short-term political health measures. So if you have a look at the government's health targets, the ones that they publish every quarter out of each DHB, they are ones that appeal particularly to the public. How many people are getting elective surgery? How long does it take them to get to the emergency department? And so I think it's short-term political thinking, and that's the main driver. Long-term planning and change doesn't bring fast political reward. It takes time to change. You take the whole approach to smoking in New Zealand. The first legislation for smoking was in 1989. Helen Clark really got drubbing over that. That this was a dreadful thing to do. Move forward to 2015 and see how the prevalence and the consumption of tobacco in New Zealand has gone down. And with luck, we could be smoke-free New Zealand 2025. It's long-term planning, measuring and thinking. And in health, you've got to be prepared to be in for the long haul. That's why I am critical of the change from things like the primary healthcare strategy. That is recognised internationally as probably one of the best primary healthcare strategies in the world. But it's there in name only in the main. So I'm a firm believer you set out a long-term approach, you evaluate it along the way, you see if you're making progress, if you're not, you change things. But if you just go for short-term fixes, political fixes for the next election, you will not improve the overall health of New Zealanders. And that's what this whole debate today is about. How do we have a more healthy future for New Zealand?
So if I could pick up on that, if you go and have a look at Finland with regard to its education system, and the fact that Finland for the last 25 years ago, agreed among the professionals that knew what was required, among a discussion with the community and with the country, they made a decision 25 years ago what was their priority around delivery for education. And no matter what Minister of Education has come in and out of that parliament, they have stayed on track because the politician's job is to fund it, not to know everything about it, although Annie knows the truth. The politician's job is to fund it, when the professionals who know what the work environment is and what needs to be delivered, explain it to them and tell them where the funding needs to go. Imagine if we did that with health. Imagine if we actually did take the politics out of health and said, what's happening down in Canterbury, and the work, it's international work. So we've got 3 pilots here now, so we've got data that tells us what we need to have. Imagine if that was what the budgets were set on, and then regardless of what government came or went, we stayed on track to where we wanted to go as a nation. That's why we have the short-term planning. It's exactly what Annie said. People will buy votes with it.
Let me tell you a little story. It's actually about Jonathan Coleman on his initial tour of district health boards on becoming minister. And one of the first DHBs that he visited, his question was, well, this is all very interesting, but where is your strategic plan? And at which point there was an embarrassed silence from the DHB board members and the senior management who were there, until someone plucked up the courage to say, well, actually, Minister, your predecessor said that we couldn't have one. And, for me, that exemplifies what Anna was saying in particular, that we've had the health portfolio managed through a political lens. So what is the way that the government can gain votes and not lose votes by managing health? And hence that extreme focus on elective surgery, because over the past, I guess, probably 10 or 15 years, actually, that has become the indicator that's in the public mind of how well the system is doing or not. So, that's an illustration of what's happened here. I guess the other point that I make, relating to my earlier remarks about what's actually driving health states and what's driving disease, is that actually, if we were to take a longer-term perspective and say, how are we going to improve the health of this nation, actually, it will require pretty fundamental changes. And governments look at fundamental change and they identify risk. So big change equals big risk. We're not going to do that.
Yeah, I can't add a lot to that either. It is the political system that does drive it, and I mean, there's a lot of things we need to do over a long time. So all these people are more experienced than I am, but very interested in pursuing the discussion.
One of the key things that NZMSA has been advocating on is the issue of NZMSA. Maybe we'll be brief on this one, but to put it simply, I guess, the current government puts it 20 million or 20 billion on the roads. 20 billion on the roads, and yet it isn't economically viable for my colleagues to do a bachelor's degree and then go through medical school without, being able to hunt for a son like that and take a year off and do minimum wage to without paying
No, it doesn't sound accusing at all. I mean, one of the things that has been an advantage out of student loans is actually having students decide absolutely what they want to do. Because we have actually had a lot of people over the years, particularly back in free education, that did degrees around all sorts of things that didn't actually get them where they wanted to go. And one of the priorities is to actually try and get the students that we have training directed into the industries or the vocations or the careers that they want to be in. In terms of nuts and bolts around how the system operates, that can be debated, but I do believe that you need to focus people into the areas that make or the systems or the places where they want to go, because what we don't want is we don't want people taking up free education for the the sake of it, not actually thinking about what it's for, and it does actually focus you on where you want to go.
It's not for the sake of it, it's something you can do. When you have a policy here that is actually discriminating heavily against medical students, we're the main ones affected by this, and there's just no willingness to even have a conversation about it in government. And it's only the National Party that are against this. Everybody we speak to can agree with this. Whether it be financial institutions, other political institutions, the universities, anyone, they will say it just doesn't make sense. And yet, why does it make sense to the National Party to make medical students actually suffer for it? We want to finish our degrees and we want to be earning money and we want to repay our student loans, which you seem to be obstructing yet also encouraging. It's a very confusing message.
You know why I don't? So I'll tell you why. I'll tell you why, because this is what happened down in Victoria when there's about 2,000 people there when I was down during the election. So the answer that they will give you is because you're going to get rich. No. That's the answer they're going to give you, right? And they're going to say to you, so why should a taxi driver or a politician want to subsidise your future earnings because you're going to get rich? Which completely ignores the fact that when a taxi driver goes to the hospital, he's going to want you there. And that's the frustration. All of us are sitting here on this side with just like, wow. Because that's the frustration of trying to have these conversations with the government at the moment. There is no sense to it. It makes absolutely no sense at all. But the young lads will come, and they'll say, you're going to be rich one day, so we're going to cut the legs off your education now.
And actually, medical students are banding it, but so are those trained to be psychologists, and so are dental students. And it is so short-sighted, I cannot understand. In fact, Kevin and I were in Otago before the last election, and the person who was in Barbara's place said, well, it's your fault, you just didn't make the right choices. Kevin and I tried to protect her from this because she didn't understand, I don't think, what impact this change that Stephen Joyce made. And I think it's now just become bloody-mindedness because all the evidence, just go back to the evidence, tells you that they need to remove this stupid 7-year barrier. We want our graduates to finish their education. I also think there's great advantage in those students who do other degrees first. Those that have done a science degree, or maybe they've even done politics. But the advantage of that, and that's kind of being said like, well, you made silly choices doing that first. But actually having experience in other things, because let's face it, you will end up as doctors with quite a narrow focus in your life. And if you've had other experiences, that's going to add to your ability to be really good doctors. And I think that this is, I predict that this will change, certainly will change a government. I think keep the pressure on. This is. I'm sure even those that are running, your teachers are saying, stop doing this to our students. It makes us a laughing stock internationally, I'm sure.
Can I ask
Just a couple of...
studied at university? Because unless you each studied exactly what you're doing as your job now, then I'm sorry, but I don't think it's with you.
I didn't went to university.
Can I just make a couple of points about this issue, just to add a few things. So we did some official information requests which showed that actually the government was totally unaware of the impact on medical students at the time that it made the decision. But they wouldn't change. And secondly, we know that those who are most likely to have done some other degree prior to medical training, Māori are much more likely to have done another degree before going to medical training, and to be affected by this policy. And those students who actually go into general practice also are more likely to have done some other training in addition to the medical training. So that it's at every point it's cutting off the nose to spite the face.
I just want to say one other thing too. The statement that we want to make sure people don't waste their time studying stuff that actually doesn't end up with a job over here, is again a short-sighted view. That means that there's no point studying Greek philosophy then. What's your job going to be? How can you narrow it down? And the reality is that you don't get people like Stephen Jobs or people that create and innovate unless they have had the opportunity to think wider than a job.
In answer to the question up here, I trained first of all as a school dental nurse. I didn't do any of your teeth, it's too long ago. But then I went to Waikato University as an adult student and studied history and politics. So I had two chances. And I did it in a day when we didn't have student fees and didn't need student loans.
One of the key issues, and this is based on the study ever since I've been here, is the first question: do you believe there should be a limit to the number of years a student can invest in interest-free loans? And if so, is 7 years too short?
It shouldn't have to be the loan.
So I think, to my perspective on that is that the primary benefit, so from an economic point of view, the primary benefit of your studying medicine is not to you, it's to society. And so it's a public good is the major benefit of actually educating med students. So that's why it should be publicly funded. And actually, in general, the major benefit of someone actually doing post-tertiary training of any sort is actually to the wider public. It's a public good, not a personal benefit. So if there is going to be a student loan scheme and there is a limit, then 7 years very clearly is too short.
We haven't got a policy to get rid of student loans, but we've brought in interest-free student loans. And the submissions made to me in this area is that probably 10 years, because you're not talking just about medical students, you're talking about those that do postgraduate education, engineers and whatever. And the area is around 10 years. Now, that is, we don't have a policy of that at the moment. We've certainly got rid of the 7 years for medical students, dental students, etc. But that is coming forward now as all those that are doing postgraduate studies, higher education for the benefit of New Zealand, are very disadvantaged with the current law.
I just say my qualifications. Because I'm background. So my first degree was maths and geophysics. I've got most of a BA in Scandinavian studies. I just need to do another couple of stage one papers at some time. And a diploma in postgraduate diploma in yes,
Yeah, actually, I've got UE as well, and I've done accountancy papers, and I've also done a lot of leadership and training in MBA, not through university system, but through the Institute of Strategic Leadership, and I've also studied through Lincoln Caliber Leadership and had scholarships to food and business marketing overseas. So I've done a whole lot of education all over the place, and I guess my question before you were talking about, I know people have various parts in their career, and mine certainly changed from, doing accountancy to being a dairy farmer to being on regional development boards to being on industry boards, and a lot of you will actually face that situation because I meet people now who are CEOs of health boards who actually, had that medical training first. And so, some of you will actually be doctors for quite some time. You might be specialists, or you might actually end up in the administrative or management or whatever side of it. But actually, the degree that you do, or the stuff that you do on the ground, certainly helps you do those high-level management jobs in the future. So, no education is ever wasted. But I do think we've got we've got a lot of industries in this country that are calling out for people, and we do need to make sure that our education is pointed in this direction. Deeper understanding within it, and the others on the committee to actually understand it better, because I couldn't sit here and tell you what, obviously for political reasons people work out, there's a debate, and a number is put there for various reasons, but I don't think at the end of the day we all have different philosophies about how we might get there, but I mean, things change over time, and what I'll commit to you to do is to actually understand more about what the 7 years means, because, nothing's fixed in stone for young, so yeah, I'm happy to. I'm here to learn and listen. I want you to tell me as much. You can tell me more than I can tell you, because I have a belief, not only in my electorate, but in my country, that actually 80 or 90% of the good ideas actually come from outside of Wellington, not inside of Wellington, and it's our role to listen and learn and actually communicate and collaborate with our own parties and with other parties in terms of how things move forward. Yep. I can give you my card. And we can arrange a meeting, and we will arrange a meeting, and I'm very happy to talk to you about it. Hey, I pride myself on being a common sense person that, and if I think something's a stupid idea, I'll tell you. I can't commit to change the world, but what I can commit is if I think something's not right, I will lobby my colleagues to change it. So I'm very happy to listen and learn.
So free trade agreements are usually nowadays not really about trade at all. They're actually about giving the big corporates access to the cheapest labour and the lowest environmental protections, referred to earlier comments. And the TPPA goes further, like it's one of these investment treaties rather than trade treaties, and essentially elevates the rights of corporates ahead of those of citizens and ahead of the national sovereignty of the countries that are party to it. It's a bad deal from every possible perspective, and you'll be familiar with the issues related to farming. And it already mentioned that we're already having these investor-state dispute provisions in other agreements effectively held over our heads in relation to plain packaging, and actually another more robust investor-state disputes provision actually will have a chilling effect. So governments in the future will say, well, it's not worth even starting because actually we're just going to face that sort of action.
Let's not forget that the first one of these was in the China Free Trade Agreement. So the first one of these investor-state disputes clauses was in the China Free Trade Agreement, hence why New Zealand first opposed that agreement. And the next one, I was briefed at the Foreign Affairs and Trade Select Committee on the Korean agreement. And the Koreans got absolutely nothing out of that trade agreement except that. Why would a whole country give you a whole lot of trade from one side to get a single clause that says that they can sue you if you pass laws that actually interfere with their company's trade? So there's no benefit to New Zealand as long as that clause is in that agreement, then we should stay the hell away from it.
First of all, we support free trade agreements in general. We think they're good for New Zealand. They create jobs and opportunities. We are a trading nation. We survive by exports. And so we support them, and we are particularly proud of the free trade agreement with China, and it has brought tremendous benefits for us in terms of jobs. In terms of the TPA, we actually don't even know what's in it. We're told what the think's in it, and that is our first argument. I'm told that Malaysia, the government of Malaysia, is going to expose what is in the agreement before they sign up. That is one government that's able to do it. So our argument is, why can't our government tell us what is in the agreement before we sign up? I think what might help us was the decision by the Senate last week in America, in the US, when the Democrats voted against, and I'm not sure of the name, something like Free Trade Protection Agreement, not allowing the government to have a sign up to something they haven't seen, basically. I think what we want to know is what in it. I totally agree with the argument that we should not put at jeopardy our public health, our approach in terms of farming, our environment, and in terms of intellectual property. If those things are at risk, then we shouldn't sign it. But what we need to know is what's in it. So I can't say totally opposed, because I don't know, and none of us actually know what is the most secretive agreement. And in fact, the China Free Trade Agreement was far more open than this one. And so let's see what's in it. And our pressure goes on the government and the parliament and political parties saying, show us what you're signing up to before you sign it.
And look, part of the reason why we don't know what's in it, I don't know what's in it, the negotiators know what's in it, because if you can imagine trying to negotiate an agreement between that number of countries with actually people around that's still actually in the process of negotiation, it's based on prior trade agreements, and so it's still actually being negotiated. But you can be jolly sure that the government will be intent on not putting anything in there that's going to be detrimental to our future. It's got a long way to go. I think, as Emmett said the other day, the move in the US has actually slowed it down quite substantially, I believe. And but you can be rest assured that they're not going to be wanting to negotiate anything that's detrimental to us. But if you actually opened up something like that while it's still in the negotiation phase, where even the negotiators are negotiating what's in it, it becomes very, very difficult.
I actually think they've finished the negotiations. That's the point. I think they're actually finished the negotiations, and they were looking to, in the US Senate, to actually put down what has been agreed.
Yeah, I'm not sure that that's total. I don't know any more about what's in it than you do, but I'm not sure that that's totally the case, because my understanding is that there are still parts to it that are actually being, moved around.
It's a bit of a shock that a member of the current government who's going to sign it doesn't know what's in it either.
I think Tracy's government is actually, the cabinet is government. There's a certain amount of things as backbenchers that we will be exposed to at the time that we need to be.
You'll be part of the government that signs it.
Yeah, but what I mean is there's a certain group. Look, I'm not disagreeing with that. All I'm saying is that actually you can't have 60 people in the room trying to help part of the negotiation either. So, 59.
We only have 5 minutes left, and I know.
Egg and cheese.
So, I do apologise, but I still see there's some hands up, but I'm going to try and bring this to a close, because 5 minutes is a relatively short time in the answer question for politicians. So, I'm going to ask the final question. If you were the Minister of Health, what would be the first thing you would focus on?
Well, for me, it's how we distribute health to all of our. So I opened my speech with when I said before is looking at the different ways of healthcare that get primary healthcare to every person in our population.
That's almost impossible to answer, because there's so many things you'd need to concentrate on. But the first thing I do as Minister is I want to know the truth. I want to know where the money's going. I want to know what's being undertaken in the name of health, what's working, what's not working, and I'd want to then engage with those who can provide me with the very best of advice.
If model, return to a high trust model, strong transparency, making sure you've got KPIs in place that are actually met, and then allowing the professionals to do what they do.
It's a pretty challenging question, actually. I think probably, aside from like changing the budget, probably the first substantive thing that I think is important is to establish the mechanism by which the health sector can liaise with and work together with other sectors, housing, education, social welfare, because those sectors actually have greater impact on people's health status than the health sector does.
I just, what I just said at the beginning is that I want to work out what are the right models to actually get healthcare for primary care for everybody in our community. So pretty much I answered the question prior to the other three who answering.
With that, I think it's time to draw this to a close. As adjudicator, it's been my great pleasure to attend this event, and I certainly like to thank you all for listening to for debaters. Thank you very much, Barbara, Tracy, and Kevin for taking time out of your Saturday. I hope the hurricane turns tonight. I'm about to take away myself. And I'll hand it over to